Welcome, everyone, to today's Schwartz Center Compassion in Action webinar, The Evidence Explained, Why the Schwartz Rounds program works. Thank you for joining us. I'm Julie Collier, Senior Director of Programs here at the Schwartz Center. As many of you know, we are a Boston-based nonprofit organization established in 1995 to champion compassion for all who seek and provide healthcare. Our mission is to partner with healthcare organizations to advance compassion for patients, care teams, and their healing relationships. Through innovative programs, education, and advocacy, we support healthcare workers' well-being and foster meaningful connections among healthcare professionals, enabling them to provide the empathic, person-centered care that every patient deserves. Before we begin, I'd like to share a few details about what you can expect. Please note that the program will last 60 minutes with a panel discussion for the first 40 minutes or so, followed by some time for questions. Feel free to enter your questions in the Q&A pane throughout the discussion. I'd also like to acknowledge with gratitude that this Compassion in Action webinar series has been funded in part by a generous donation made in memory of Julian and Eunice Cohen, as well as through year-round support from our national business members. With that, I'll hand it over to Dr. Michael Gustafsson, Schwartz Center CEO.
Hi, good morning and good afternoon, everyone. Thanks, Julie. Thanks to all of you for joining us today. I'm really excited by today's topic. As many of you know, we are celebrating our 30th anniversary at the Schwartz Center for Compassionate Healthcare. And shortly after our founding in 1995, we gave birth to our signature program, which is Schwartz Rounds. And the history of Schwartz Rounds is fascinating in the sense has grown from one hospital to a few to many across the United States, Canada, Australia, New Zealand, the United Kingdom, and Ireland. And today we're going to hear a little bit about that journey and a lot of the research that was done on Rounds benefit in the United Kingdom and Ireland. So it's really an honor today to have our guests, our panelists, to really help dive into the research behind Rounds. So I'd love to introduce Jill Mabin, who is a PhD and RN, is a professor of health services research and nursing at the University of Surrey, and a National Institute for Health Research senior investigator. Jill led the first national evaluation of Schwartz Rounds in the United Kingdom, providing evidence of their impact and how they actually work to produce their impact. With Jill today is her colleague, Jeremy Dawson, a professor of health management at the University of Sheffield. Jeremy's research includes a range of topics in the areas of health services management. He has led several large-scale projects in the NHS, particularly focusing on staff well-being and its linkages to patient outcomes. Jill and Jeremy, thank you so much for joining. We're really looking forward to the discussion today.
Thank you very much. Absolutely delighted to be here, and thank you so much for the invitation. I'm going to now share my slides. Okay. And start this presentation. Hoping everyone can see that slide. Yeah, pop that down. And then bring the slide up again. Okay. So yes, Jeremy and I are going to talk to you. Jeremy and I worked together on our evaluation that was funded by the NIHR, and we work with other colleagues. Jeremy at the University of Sheffield, also Imelda, and then colleagues from the King's Fund and colleagues from King's College London. I used to work at King's College London. That's when I did this study and led this study. So thanks to all my co-authors. So just to introduce the study to you, we undertook this national evaluation between 2014 and 17. And there was 4 discrete parts. There was a literature review, there was mapping with what was happening in Schwartz Round sites in the UK. And then there were these 9 in-depth case studies and the staff survey. And this is the data that I'm mainly focusing on today. I'm going to present the in-depth case study sites, and Jeremy's going to talk to you about the staff survey. So just going to give you an oversight of our key findings here. So won't be any surprise to any of you who perhaps know the research, but also know Schwartz Rounds, that interviewees that we spoke to described Rounds as interesting, engaging, a good source of support. People valued the opportunity to reflect and mentally process work challenges, learn more about their colleagues, and gain insights to their management of challenging patient cases. Panelists, that's people, the storytellers, those who told stories, experienced catharsis and a release of burden. And a few questioned the purpose of unearthing feelings of sadness, anger, or frustration, but they were a few. What we found was that rounds offer a safe, reflective space for staff to share their experiences and where they self-disclose. So self-disclosure was a key element of rounds, and where they also revealed their own vulnerability and role modeled vulnerability. And that was particularly important for senior clinicians, role modeling their own vulnerability. And that was very powerful for early career and junior clinicians to see that. Rounds also offer this space to come together to interact at the group level with staff of different roles, creating a level playing field. You will all know, hopefully, that rounds are open to anyone in the organisation, whether they are a reporter, an administrator, a senior doctor, a nurse, anybody from the board. So they're open to everyone, and that's quite unique in terms of an intervention. And what we found was that they offered this unique countercultural space. And I'm going to come on and unpack these in a lot more detail. So bear with me, because you might not know what I mean by that at the moment, but I will explain. And they offered a time in which trust is built and emotional safety and containment. So psychological safety and what's called containment in therapeutic settings, where feelings are sort of held and there is support in the room, is offered. And it's this opportunity to hear and tell stories about the social, emotional, and ethical aspects of work that resonate with people, or you hope that they do. And that's definitely what we do as facilitators. I'm a Schwartz facilitator myself now, resonate with members of the audience, prompting them to reflect and further share and produce what we might call second stories. They also, we found, offer this opportunity to uncover and shine a spotlight on hidden organisational stories and roles, making people more visible and valued. And that they provide these multiple perspectives. So not only is everyone invited, but there are often multiple perspectives on the panel. So you might get 3 or 4 storytellers and have people from very different roles in the organisation sitting next to each other, sometimes talking about the same patient case and experiences, but their experiences may be very different, or talking around a theme, like a patient I'll never forget. And this provides increased insight and understanding of staff and patient experiences. And this results, we found in our study, in more compassion for self and each other, and empathy for each other and for patients. So here are these summarised, and I'm going to just dive down into two or three of those this afternoon or this morning, wherever you are in the world. And I'm going to start first with this trust, emotional safety and containment, and I'm going to give you a little bit more detail from the data and explain what I mean by this a little bit more. So we did a realist evaluation, which doesn't ask do rounds work, it asks who do rounds work for, how and why. And a way of presenting data from a realist evaluation is to either use what are called context, mechanism and outcome statements, or these if-then statements. So we have opted for if-then statements because they're a little bit more accessible if you don't know much about realist evaluation. But here what we found was that if, and there's an if, it's not always present, but if safety and trust are maximised through careful selection of stories, making sure they're not told too soon, that they're safe to tell, for example, that there has been good preparation of panellists in panel preparation, and the rounds facilitation creates a trusting and safe space for reflection, then this can lead to fuller audience engagement and self-disclosure, where there's people are willing to speak honestly and openly and authentically and admit mistakes, errors, and be vulnerable. So this is, I'm going to share some quotes from our data. So this is a storyteller, and this is, we gave our site pseudonyms. So this is Juniper site. And they said rounds are a safe space, this idea of a safe space where we can discuss things that are challenging. And it enables practitioners to be better practitioners, to be more empathic, have a moment to stop and think about themselves and their behaviours and others' behaviours. And that reflection may help in the future and ultimately may change behaviour. It's a space where people are allowed to be vulnerable and to be a human being. And I think what was reflected was that's not always the case. I think it feels like vulnerability can be very difficult in certainly healthcare as we know it, both in the US, Australia, Ireland, but certainly in the UK. And I guess that's what we're all doing at Schwartz. We were all showing our vulnerability in different ways and being honest about that and not trying to pretend that this stuff doesn't have an impact, because it does. So this panelist was somebody who told a story in Willow. So I'm now going to come on to, as I said, I'd unpack countercultural space. I'm going to do that now. So hopefully you'll know a little bit more what I mean by this. So what we found was that, as many of you will know, healthcare environments are often very busy, quite often hierarchical, and very outcome focused, very protocol driven, outcome focused, where sometimes stoicism is valued and staff are expected to prioritize patients above all else. And what we found was that if good facilitation in Schwartz Rounds places staff experience center stage, so uniquely, I think normally as a nurse or a doctor or clinician, you're always putting patients first, which can ultimately mean that you and your experiences come second. And maybe that's right. Some people might argue that's absolutely right. But in terms of looking after self, maybe it's not right. But in rounds, uniquely, staff experiences place center stage. Patients, certainly in the UK, do not come into rounds. And so if we do that, if staff experiences place center stage and we avoid problem solving and it supports a safe and confidential meeting. If so, then rounds can provide a unique physical and psychological countercultural space that encourages a shift in what's valued and expressed. So, for example, emotions can be expressed. There is often silence and stillness, and a lot of clinicians won't experience that elsewhere in their normal day. Prompting reflection, openness, and honest conversations. Staff are seen as human beings, and over time, talking about emotions can become more accepted and normalized. So that's what we mean by rounds being a countercultural space, that they're not like the prevailing culture, I was going to say sort of out there in the organization, as opposed to being in a Schwartz Rounds. And here's a quote talking about the honesty in rounds. And so to hear doctors being very honest about a difficult patient and how they handled it, I'd never heard this in this building. And I've been around 49 years, and it was the honesty of it without judgment. And I think that was the powerful thing that got to me. Again, that was a panelist, but also a frequent attender. So it's the silence, a whole new concept for most people in the audience. And sometimes you can literally see people sort of relax into that and be told that silence is okay, just to go with it. Maybe a wonderful release. And this idea of leveling and a flattened hierarchy, so everyone is equal in a round, regardless of your role in the hierarchy in the organization. So I think there's also something about flattening hierarchies. So we've had the most senior manager on a panel with a receptionist and with, I think, a nurse, and seeing them all side by side and clearly struggling with the similar dilemmas brings everyone down to the same human level, which is helpful. People also talked about it as this giving them time and space for stepping off this incredibly busy treadmill that they're usually on. So it's allowing you to step off the treadmill a moment and reflect. And then I think this will improve patient care because you're going to be less reactive. And giving this headspace to relax, to reflect, sorry, not relax. Rounds provide uncluttered headspace where people can put the brakes on. You can stop, you can leave that constant drive for performance targets at the door, and you have that clarity where you can just breathe and start thinking with like-minded colleagues who experience the same pressures. Being able to sit with the emotion, be with the emotion, that you normally just push it down and move on to the next task. So that ability to reflect on your practice and have that headspace, that's where the opportunity to do things differently comes from. So hopefully this is all giving you a sense of how and why rounds work. So I'm now going to move on to this other point here, which is looking at giving context, greater context to patients and staff. So greater context allows better interpretation of behaviours and other staff and patients. So expanding people's knowledge of patients and staff through these multiple perspectives leads to increased insight and understanding of staff and patients, resulting in more compassion and empathy. So in terms of patients, When different panelists talk about the same patient in a case study round, for example, this provides a multi-dimensional perspective on the patient. And for staff, when panelists share their experiences authentically and hear how others describe the view of the staff member and their role, that gives greater context and insight too. So I'm just going to share some quotes around this. So in terms of patients, it was very much said to us that it was like trying to walk in their shoes, and that definitely increased empathy. So having greater insight into people's behaviour, I think it's enabled difficult patients, inverted commas, or difficult cases to be understood and digested in a more constructive way, in a less defensive way, in a more reflective way. It's helped people understand the more complex and more challenging cases and why people behave like they do. And having this greater insight into people's lives, having this multidisciplinary group with people from maybe outside the hospital, from the community, for example. So while it's certainly changed the way I view patients, I think I'm much more aware of their backstory. In some of the rounds, occupational therapists have talked about seeing the patient's home life. They visited their house and how chaotic and dishevelled many people's lives are outside the trust. And of course, normally, as a clinician in or anybody in an organization, you don't see that. You don't see that at all. So the backstory and that context is lost. And that rounds, this is brought into rounds to enable this greater context. And in terms of empathy, it makes us think about what we're doing, and we're walking in their shoes a bit more. I think also you reflect on and you internalize what you've heard. So even subconsciously, you think, I might try that a little bit differently, or do that a little bit differently. And in terms of generosity, you're much more sympathetic and tolerant. So this is about contextualizing staff, sorry, so staff on staff. You're much more sympathetic and tolerant of the decisions other people make. Rounds are really helpful in reminding us that everybody is trying to do their best, and to have a more generous understanding of other people's difficulties and how hard everybody is trying, which makes it easier to be generous to ourselves then as well, acknowledging that we do a really hard job. And in terms of empathy, I think I've got a bigger understanding as to how other people's minds work, other staff, and what other people have to put up with in their jobs, how challenging they are, really understanding where other people are coming from. And I have more empathy towards other staff members and colleagues, but also patients as well. So I think I'm now handing over to Jeremy. Are you there, Jeremy? I've removed my pictures. I can't see if
Thank you,
you're
Jill.
there. Okay.
I'm here. Hopefully people can see me. And thank you very much for that. Yes, I'm going to present the findings from the staff survey we did as part of this work. Now, the staff survey was approaching this in a slightly different way. Jill's been talking about how and when rounds work for whom and in what circumstances. The staff survey was more concerned with looking at what the overall impact was for staff on their experience at work, on their well-being. So if you can move on to the next slide, Jill, please. What we were wanting to do was look at the impact that attending rounds had for staff when they were coming at them for the first time. This meant that we had a real logistical challenge in terms of being able to recruit people to the survey. And in reality, what this meant was that in the 12 sites we were working in, as researchers, we went along to usually 3 or 4 rounds in each of these sites and approached people as they were coming to ask them whether they had been to rounds before. And if they hadn't, if they were approaching for the first time, we would ask them to complete a baseline questionnaire for us. And I'll talk in a moment or two about what was on that questionnaire. We would then send these same people a follow-up questionnaire 8 months later, by which time we were hoping they would have attended more rounds. And we actually defined someone who attended at least 50% of the rounds which were available to them in that 8-month period as a regular attender. And so we actually managed to get a sample of 51 regular attenders who had started attending rounds for the first time, as well as 205 irregular attenders. Quite a few of those might have just attended the 1 round. Some would have done 2 or 3. In most cases, the rounds were done on a monthly basis in these sites. But we also had a control group. We needed a control group of people who didn't attend rounds at all. So for that, we sent a questionnaire to a random sample of staff in each organisation electronically. And we asked them, first of all, if they'd ever attended any rounds. And if they had, they would be automatically excluded. But if not, they would be included as a potential member of the control group. So if you can move to the next slide, please, Jill. On these questionnaires, we were looking at a number of different measures. There were two key outcome measures we were looking at. One was people's psychological well-being, measured using a tool called the GHQ-12 or General Health Questionnaire, 12-item version. This is a measure of psychological strain, and it's done in such a way that if people respond positively, very positively to at least 4 of the different questions, then it's an indication that their level of strain is high enough to warrant some sort of intervention. We also measured work engagement, which may be less familiar to some people, but it's a measure of it's defined as a positive work-related state of mind, which encompasses vigor, absorption, and I've momentarily forgotten the other one. But essentially measuring how well people are working when they are at work. We also looked at a number of other outcome measures as secondary measures, things like self-reflection, empathy, communication, compassion, peer support, and organizational climate and absence rates. So we asked these at both the baseline and after 8 months for the control group and for the rounds attending group, whether regular or irregular. We also asked a number of questions about their demographic status and their work role, so that we could adjust for any differences there might be, especially between those in the rounds attending group and the control group. So next slide, please. The key findings here. First of all, in terms of psychological well-being, what we saw was there was a statistically significant and also fairly sizable improvement for people who attended rounds regularly compared with non-attenders. This is shown on the bar chart at the top on the right there. And you can see that there is a substantial reduction amongst those who were attending rounds and only a very slight reduction amongst those who did not attend rounds over this 8-month period. And in a moment, I'll show you what that looks like in a slightly more intuitive way. In terms of the other outcomes, it was less clear-cut. For work engagement, we didn't see a statistically significant improvement, meaning that even though there appeared to be a slight improvement in engagement for attenders and a slight decrease in engagement for non-attenders, that this was not something we could say was a statistically reliable result. And in terms of the other outcomes, most of these showed changes in the expected direction. Sorry, the word direction has dropped off the bottom of that slide. But a lot of these were not statistically significant. However, it did confirm that the rounds were generally working in the way we thought they might. It's just that because our sample was not as large as it might be possible to get in other circumstances, we weren't able to show all of these were statistically significant. But just to talk about this psychological well-being finding a bit more, if we can move on to the next slide, please. This is particularly worth looking at because the study was designed to be able to show a difference in this particular outcome. And we did see this at the start of the study. So this is the baseline measurement. We can see that 37%, that's illustrated by the 37 green coloured people here amongst the 100 there, of those who didn't attend rounds were high on this measure of strain or well-being. In other words, they probably would have benefited from some intervention. Amongst those who attended rounds, this was 25%. So we already see a bit of a difference there, which might reflect something of the difference between those who were able to attend rounds or not. However, we did adjust for this as far as possible during the study. And if you click onto the next part, please, Jill, what we see is really stark 8 months later, in that in those who didn't attend rounds, there was no significant difference, barely any change, just from 37 to 34% of those who were experiencing high levels of strain. Whereas among those who attended rounds, it had gone down from 25% to 12%. So less than half of those who were experiencing high levels of strain at the beginning were then experiencing them 8 months later. And while we can't say for certain that this was due to rounds attendance, because we adjusted for as many other things as possible that might explain that difference, we think there's a very strong case to be made that rounds played a substantial part in that. And with that, I'll hand back to Jill to talk through the rest of this.
Thank you very much, Jeremy. So building on Jeremy's excellent work there, we, from our case study in qualitative work, the realist work, we did find other reported outcomes. We couldn't demonstrate these in quite such a convincing way, but people reported improved teamwork and communication, increased empathy and compassion for patients and carers, for other staff and for self, as I'd already explained. Decreased isolation. People didn't feel so alone. They often thought it was only them who felt a particular way. And that also happens with our students, which I'm going to come on to. And they also reported positive changes in behaviour and practice. So maybe, although rounds aren't outcome orientated and you don't go away with a sort of to-do list, and that's what also makes them countercultural, there were changes to protocols. New groups were set up, maybe for newly qualified staff or night staff, for example, so they didn't feel so isolated. And behaviour was reported to have changed. And what I remember one of the quotes people saying is allowed a fertile soil for things to grow, and that conversations have really changed in this organisation as a result of rounds. There were challenges, and so not to sugarcoat everything, there were some things that were difficult. Rounds attendance was definitely an issue for some groups, and that was often ward-based staff in terms of nurses and healthcare assistants and community staff. And that was off when we did our evaluation. Most rounds were face-to-face. There really wasn't the appetite for online rounds that we now see as a result of the pandemic, where everything shifted online. And so often those ward-based staff, so community staff, couldn't necessarily get to a place easily where rounds were running. And for ward-based staff, rounds, I mean, people tried with different times, different times of the day, different days of the week. But for ward-based staff, it was difficult because they often happened at lunchtime, and it was people who had some control over their own schedules that we often saw at rounds. So more senior nurses, for example, ward-based staff might often be giving out meals or feeding patients, and if it wasn't at lunchtime, they'd be doing something different. What were enablers was convenient location, as I've said, and freedom over your schedule to schedule your own work in the day. Barriers were sometimes a lack of understanding what rounds were, and a conflict with clinical priorities. I don't know if you have this in other countries, but I guess, of course, they're named after Kenneth Schwartz, but actually calling something a Schwartz round doesn't always tell people what it is and what it means for them. And we have encountered quite a lot of misunderstanding. Did you need to be invited? Was it a research study only? How do I get there? And then people very confidently told us they'd definitely been to a Schwartz round, and then we explored it a bit more and they definitely hadn't. So there was some real misunderstanding about what rounds were, and I think many of you on this call will know that the comms and the communication and the unpacking and letting people know what they are has been one of the challenges. And also this idea that they conflict with clinical priorities. So with the best will in the world, if you want to go to a round, if your clinic's scheduled for that time or there's a really sick patient, of course you can't go. Sufficient organisational support was really important. Apologies for that typo there with the 9 instead of the bracket, but that really included administrative support. Those organisations who didn't have much administrative support really struggled because most people were running rounds on top of the day job and often were clinicians and had very busy jobs already. The requirement for an active steering group, we saw where there was an active steering group and people really supported the facilitator and clinical lead to run rounds, that was really positive, and a facilitator, and where there are enough resources. As you will know, in the contract, their food is provided, or face-to-face anyway, and it was really often quite difficult, more difficult than you'd ever imagine, to get a budget for food for staff. So that was sometimes difficult. And some individuals, rightly so, they're probably not for everyone, decided rounds were not for them, or they were not accessible by everyone. Some people said, I really don't want to be upset in the middle of the day and then have to go back to work. So we produced an organisational guide. We had forwards by very own Beth Lown from the Schwartz Centre Boston, Jocelyn Cornwall, who developed and initiated and was director of the Point of Care Foundation, who brought rounds to the UK, and Sir Robert Francis QC, who led the Francis report, which looked into the failures at Mid Staffordshire. And in his report, he recommended rounds. So they all wrote a forward, and in there we distilled these recommendations, and that's available online. I think it would have resonance in many places. Actually, it's not just only UK relevant. We also produced a film to understand Schwartz Rounds, and we've embedded our findings in there, so please have a look at that. And I'm now going to move on very quickly. Michael and colleagues at Schwartz Centre Boston asked me to share some of the work we've done about evaluation of rounds in higher education institutes. So I'm just going to share some of that work now. It was not such a big study. It did not have the generous budget that we had for the NIHR national evaluation. So we did not do a control group, for example, and we did not do these multiple questionnaires that we did, that Jeremy's talked to you about. And yes, you can have the web address. All these resources are going to be sent to you afterwards. I'll give you the web address, I'll give you some of our papers, and you can absolutely have these slides. So definitely we'll share all those, so please don't worry. So this evaluation was a little bit different, but at the moment, I think not every country runs rounds in higher education institutions, so basically universities. At the moment, 34 HEIs are running Schwartz Rounds in the UK, one of which is my own institution, the University of Surrey, you can see down the bottom. And we developed and ran something called Schwartz South, and the University of Surrey was the hub, and these organisations were what we called the spokes. So it was a hub and spoke model where we were sharing our expertise and our knowledge, and we got money to pay for the licence fee and invited organisations, universities in the south of England to apply to be part of Schwartz South. And then we had various webinars and training. These facilitators in these sites came and viewed our rounds, we saw theirs, we learned from each other. And so this went on for 2 years, and that was funded by Health Education England and supported by the Point of Care Foundation as well. So this was Schwartz South. There is also a Schwartz North and a Schwartz Midlands. So we have these groups that have really spread the word and helped spread the learning across the UK. So we did do a small evaluation. So we had 2 cohorts who were the cohorts are the organisations, the universities. So we had 3 initially in 2022 and then 3 more in 2023. And we collected data about the rounds they ran. We did non-participant observation data of the rounds, the steering groups and the storyteller preparation. We had interview data, we interviewed facilitators, steering group members, etc. And we used the survey data, which is slightly adapted, the Point of Care Foundation evaluation form, which is slightly adapted based on our previous work that I've just shared. So in terms of the overview, during the study period, rounds were implemented in 5 of the 6 universities. 2 have now sadly discontinued, and that's because the facilitator left. And I think once the funding that we offered ran out, it was very difficult to secure more funding. A total of 32 rounds were run, and that's between 3 and 11. Different organisations ran only a few, did one a term or something, and one did 11. There was a mixture of online and in-person rounds. The number of storytellers ranged from 1 to 4. Attendance range was between 3 and 116, with an average of 34. And there was steering group attendance at all HEIs, which was good. In terms of data collection, we observed 14 rounds between 2 and 4 per university. We had 14 steering group meetings observed, 10 storyteller preparations were observed. We conducted 19 interviews, and we had 520 survey responses from attendees. So in terms of which students are attending, this was largely determined by the courses that were run in these universities. So, for example, in our own university, we've only just got a medical school. So during this period, we didn't have a medical school. One of the sites had a medical school, many others didn't. But as you can see, it was predominantly female attendance. There was quite a lot of people attending in year 1 of their studies, and that was probably because it was kind of put into the curriculum in year 1. It wasn't mandatory, but it was in the curriculum, and so lots of people came and then found they got busy and it kind of dropped off a little bit. There were mostly nurses, as you can see, adult nurses, some from child and mental health nursing, but there were some from paramedic science, occupational therapy, midwifery, and social care. So how did the students rate rounds? So this is very good, there we go, exceptional, excellent, or good. We do find in these evaluation forms there is a bit of a ceiling effect, and we don't really, it doesn't feel that they're always very discerning, or maybe they just are always excellent. We'd like to think that, but yes, here's a couple of quotes from some of the students. Really touching, privileged to be part of this. Round went very well. Atmosphere created by all participants was warm and trusting, and will attend again if in the nearest opportunity. How did they impact students? Students talked about this not feeling so alone, feeling more connected to my colleagues, hearing their stories, knowing people feel similar to me. I think it was a surprise to students that they weren't the only one feeling in a particular way. And they reflected on this importance of reflection, own and others' experiences, gaining new perspectives, sharing the load, connecting with others, and feeling part of a team. Another slide, very similarly, reminded me why I originally fell in love with nursing and gave me a bit of extra motivation going forwards in finishing my course. People talked about learning for their own practice, feeling more equipped, adapting practice. First years talked about how valuable it was to learn from second and third years in rounds, how to hear that they'd overcome things, having pride in the profession, reaffirming career choice, as that quote says, being motivating and inspiring, and acknowledging some of the difficulty in the profession. Some of our students say this is the only place we really get to talk about these things. So a bit like in this study, that countercultural space, not quite sure it's so countercultural in universities, but there's definitely, this space is not always provided for students in their courses. Was there a difference if they're online or in person? We actually found very little or no difference. If you look at the ratings, they're very similar. As a facilitator, I'd say there's a great difference. I really like in-person rounds. You can really scan the room. You can check out how people are. I think it feels much more engaging, and it sometimes feels much more ability to be, I'm going to say playful, which sounds a little bit odd, but to really get that engagement online, it can feel a little bit more removed for me. I'm just speaking personally, but actually here our students suggested, and they're so used to being online, I think, that there wasn't so much difference for them. What enabled students to attend rounds? So a bit like our national evaluation, and in healthcare, time of day being right, that they weren't in placement, and that they saw the poster and the topic being advertised, so that kind of resonated with them. And so this is some of our own student experiences at Surrey. And one of our students very profoundly said, it's such an important space for me and I wouldn't still be on the course without rounds. And it was great to see that I'm not the only one struggling with confidence. Having the opportunity to discuss this in a controlled environment is what keeps us going. And I really enjoyed the session. Lots of people felt exactly the same. I felt like my feelings about placement feel a lot more validated. Placements are where our students go out into clinical practice. And I thought the Schwartz Round was an opportunity to take time out for everybody, everyday stuff. And I think on a deeper level about how we're affected by our work roles. I was very moved by quite a few speakers and their concerns resonated. I found the session invaluable in terms of being able to learn coping skills. And the pictures you see here are stills from our film. We found it quite hard to reflect all of our data because actually quite a lot of what's going on in around, as these bubbles suggest, is going on in people's heads. This is what people are thinking. And we did ask people in our interviews, walk us through your reactions and what you were thinking then. So hopefully it gives greater insight. So you can find out more on our same website, and I promise I will send you the link if that QR code is not working, but I hope it is. But I can send you the link after the webinar. So that's all Jeremy and I were going to say today. So thanks to colleagues and for our funders, and thank you very much for listening. So I think I'm going to stop sharing now. I can. Make sure I can see everyone. There we go.
Excellent. Jill and Jeremy, thank you so much. That was such a great tutorial, and thank you for sharing your experiences. I've got lots of questions floating around in my head, but I thought maybe we could start with there's been some chat around the in-person and the virtual and the hybrid. You just touched on one piece of data showing that it's equivalent, but we get a lot of questions around so much of the research was done before the pandemic, before we moved a lot of rounds to virtual and hybrid. In the US, there was one article published last year by one of our members who did it before and then after comparison, and they showed some of the results, but I'm not aware of much other literature. So I just wondered if you have any thoughts from a research and evaluation perspective.
You're right. I think the research hasn't really caught up with the big seismic change we've had since the pandemic. We did an evaluation, which I can also share after this webinar, about a sort of what the point of care offered in the pandemic. It was called Team Time. So it was a way of helping everybody move online very quickly. And I suppose the differences there between Team Time and an online Schwartz Round were that they were more recent stories. They might be given, you might do the round or the Team Time round within a specific team, hoping to replicate trust and support that was already in the working environment. I think there was a great worry about going online and trying to make a sort of safe and psychologically safe space. So I think that was the thinking behind that. And I think it was quite difficult sometimes for facilitators to always feel they did have safety in the room. As I was explaining, I think you can feel the atmosphere. You kind of have a greater sense of what's happening in the room when you're face to face. And we have the experience, certainly with our students, that they often don't turn their cameras on. So you're talking to lots and lots of black boxes with names, if you're lucky. And so it's quite hard for some of our storytellers to really feel that they've got an engaged community. So yeah, that's just some sort of small findings of that. But I can share that. I'm not sure I think we have published that. Yeah, we have published that. So I'll make sure I send that paper as well if that's of interest.
Excellent. Thank you. Yeah, I think it's certainly we've realized with our members that if you're doing hybrid or virtual, there's just a different set of issues to think about and how to maximize participation and safety, et cetera.
Definitely. All I'd say is that our students were very, very engaged in the chat. They used the chat box a lot more than we anticipated. So that was quite encouraging. And then we might use that to say, if you don't want to speak, that's fine. But I noticed you put this in the chat. Would you like to say it? And often they did then come in and expand. And so that was quite interesting. We were worried nobody was going to say anything and there was going to be nothing in the chat. And there was a lot in the chat. So that was good.
So for both of you, probably the biggest question we get from sites is, can we demonstrate a connection between doing Schwartz rounds and some of the bigger outcome measures like burnout rates from providers and leaving the institution, turnover rates? I know that's tons of research methodology challenges, but I wonder if you could just speak about, from your perspective, you've thought about this so much, how you think about those organizational metrics and the impact of something like rounds.
Sure. Shall I take this one, Jill?
Please do, Jeremy. You can have the tricky one.
So It's a great question, and one that it would be absolutely possible to do in theory to test that. The difficulty is, from a practical point of view, you would need to have a much larger sample of people attending and not attending rounds to begin with, and also probably a much longer follow-up period, because it's unlikely that you'd see many symptoms of burnout or indeed people leaving an organization within an 8-month period or even within a year or two. But if you were able to follow this up over, say, a 5-year period, then that would be entirely possible to do it in theory. Obviously, from a practical point of view, then that then becomes quite difficult to organize, quite expensive to run, and so on. And which is why I think we chose this measure of psychological strain to be one of our key measures here, because that is something which is fairly close to burnout. It's not the same as burnout, but it is probably adjacent in terms of the importance on an individual's well-being. And that's something that we did manage to see this change in within an 8-month period. So I would be not at all surprised to see that we did see positive effects on these other outcomes over a longer period as well. But unfortunately, we haven't got the research to show that definitively.
Yeah. And then you can rely on the other literature that would show the connection between that measure and burnout in some of the longer term.
That's absolutely right. There's a lot of literature showing that this measure of well-being or strain, however we refer to it, is linked to all sorts of other negative outcomes in the long term.
Yeah. Turning to the HEI experience or in general experience with learners doing rounds, I wonder if, what your experience has been, what unique issues or concerns do learners or students have when they're participating? Or what do you need to be cognizant of if you're going to introduce something like this?
Yeah, I think we've had to be quite careful that it's not seen as mandatory. I mean, I know rounds aren't mandatory, and I think there's sometimes a temptation to put rounds on the timetable. And when they're on the timetable, even if they're not mandatory, they might appear to be mandatory to students. So I think that's been a challenge, and we haven't always got that right. I think also we thought we couldn't invite first years because they wouldn't have enough clinical experience, but certainly in the UK, quite a lot of them have pre-training, pre-education clinical experience, and actually what they wanted to do was also hear from their colleagues who have gone, you know, further ahead than them. So we started inviting first years. We actually invited them by accident at Surrey the first time, and then we thought, well, this is working and this is great and they love it. So we now have a scheduled session in their first term. I think the other thing is really the psychological safety. So many of us, I'm a professor in the university, so I don't teach all the undergrads, so they don't know me quite so well as one of their lecturers, and that's probably quite helpful. We've wanted to kind of make a distinction between us as teaching staff and lecturers who evaluate their work and who are going to make sure whether they pass the course or not, and wearing and being a Schwartz facilitator. So whilst so we don't have any of our other faculty come to Schwartz Rounds for that reason. So we only have the facilitators in the room to try and create that safety, because there's a hierarchy and there's a power differential, more so I would say than in healthcare. So we've been quite mindful of that. And so we always talk about wearing different hats. We have quite a good lead-in speech saying you're not being assessed, you know, this is a safe space, it's confidential. So that has required a bit of work. I think the other thing we found, some places do it a bit differently for us. We ideally wanted to get our clinical colleagues coming in from clinical practice to share stories and to talk about the real world out there and bring that expertise in. That has been quite challenging. And quite difficult to do. So for more pragmatic reasons, certainly at Surrey, we have our students as storytellers, so that our students will be telling stories to their colleagues, their peers. That's not the same everywhere. The University of Liverpool, for example, does have clinical colleagues come in. What it means for us is that we tend to have to do themed rounds. So a patient I'll never forget, or what keeps me awake at night, or when things don't quite work as planned, whatever the theme and the title might be. Whereas at Liverpool and other places, they can do patient case rounds a bit more. So I think that's quite a difference, but different places do it differently. In some places, you don't always get the range of multidisciplinarity. So it's not quite so interdisciplinary, and that's potentially a bit of a weakness. But what can we do? You know, is better. What we do is better than not having them, but it's not quite the same as everyone is invited and anyone. So yeah, but we also run at the University of Surrey, and a couple of other places do it. We run Schwartz Rounds for our faculty staff as well. So students don't come to those. So we have our own safe space. We originally put it on as a pilot round, just to show everyone in the faculty what rounds were, so they could spread the word to students. And they loved it so much, and they said, well, we want this, why aren't we having rounds? So they will often talk about the challenges of their work, and that might be in clinical practice as a practice educator, but it may well be the challenges of university and the pressure to publish and proceed, you know, succeed. Or, you know, it can be about bullying and harassment issues that can occur anywhere, you know, that can happen. Or we've had an EDI round, equality, diversity and inclusion round in our university. So there are quite a number of differences, and look forward to talking with you more about that in due course, Michael.
Yeah, thank you for sharing that variation. Just to elaborate on the participation, it sounds like many different disciplines depending on where this is occurring. And maybe you can just hit that again. So medical students and other disciplines, and what's been the experience of doing it together for the students?
Yeah, I think it's really good. So at Surrey, for example, I can talk best about Surrey, but we have clinical psychologists in their final year, and they're often very insightful and bring quite rich stories. We have our medical students now, and we have actually our veterinary students. So you don't always have to be looking after a human to feel the challenges of the work. So I think it's the same as in clinical practice, really. You just get what I shared, really, that greater insight into other people's worlds, other people's roles. It might help you understand that better before you go into clinical practice, and that hopefully you take that into your learning experience and into your future career. So I think it's been very valuable, not only having people across different years, but across different educational programs. It just makes it richer, really. One of our sites had police cadets, police educator, police. So that was really rich as well, and social workers and so on. So bringing that wider community experience of the challenges and emotional, ethical and challenges of those roles.
I know in the US, there's been so much effort to try to promote more interdisciplinary, interprofessional education earlier. I think one really great way to manifest that or to help it happen. So
Definitely, yeah.
I wonder, just a slightly different question, about celebrating the rewards of care and joy. And, you know, there's research about there in terms of the power of positive stories and gratitude. And that is part of the rounds experience as well, in addition to dealing with all of the challenges. I just wonder from a research perspective, if you have any thoughts about that aspect of rounds.
Not so much from a research experience. I mean, certainly in our case studies, a lot of sites did a gratitude round around Christmas. And I think you're right. I think that sort of focusing on joy rather than some of the huge challenges in their practice was uplifting, and particularly at that time of year. I don't think we particularly looked at that from an evaluation point of view. We didn't compare joy rounds with sad rounds, for example. And yeah, our next round for our students is one about showing gratitude and yeah, what's positive.
Joe, as part of this national evaluation, I know you looked at some of the factors to preserve fidelity of rounds as it's migrated from one place to another. It could be even within the US. I wonder if you could just speak to a few of the key findings that you discovered.
Yeah, certainly. So I think one of the key things of actually going to these 13 sites that we had, with both with the survey and with the case studies, is that we noticed that a round was a round was a round. They were very, very, very similar. And that was enormously striking, because in most interventions, you don't get that same similarity and same fidelity to a model. I think what has, certainly in the UK, and I can only speak for the UK really on that evaluation, what had really strengthened that was the contract between the Point of Care Foundation and Boston, and what was in the contract. So this need to provide food, There need to be facilitators, 2 facilitators, not facilitated alone, etc. And then I think the training that Point of Care Foundation put in really made it very, very structured and similar. So they always last an hour. They always have 2 facilitators. They're generally not run if there aren't 2 facilitators. There's always a clinical lead. They're not problem solving. And all of that is dealt with in the training. There's always food, face-to-face rounds anyway. Some of our sites give students a little tea bag and a biscuit and things to pick up to take home to when they're on an online round. So I think it was the contracting and the infrastructure and the structure that was put around it, and the comprehensive training program and resources that we certainly had in the UK that really made them very, very similar and strengthened the model and the intervention.
Thank you. Because it is hard when you spread an intervention to have it stay.
Definitely.
Yeah.
Really hard, especially from one country to another. Although we speak the same language, I'm not sure we're also always culturally the same.
I'm going to try to touch on a couple questions quickly from the audience.
Yeah.
One was, is most of the research related rounds within one organization where professional workers may know each other or at least work in similar situations versus providing rounds for healthcare workers across a much broader swath, either across hospitals or settings where they might not know each other? So
Almost all of them, they didn't know each other. These are vast organizations. Some would have staff of 9,000, 10,000, some 3,000. So whoever pitched up at rounds, because it was open to all, almost all of the time people didn't know each other, didn't know the panelists, maybe knew of them. And what they said, it was always nice to put a name to a face, and I might approach Dr. X now. Now I know he's so compassionate and I've seen him in a round. But no, we did the evaluation across multiple organizations. They were large. There were some small. We did one hospice. So there people would have known each other more, much smaller staff, maybe 50 or 100. But mostly they were large teaching hospitals, big organizations like many in the US where people wouldn't have known each other.
And in quite a few cases, they were hospital trusts which actually ran more than one hospital. So you might have an organization of 15,000 staff with 5,000 each on 3 different sites. And although there was some traveling between sites, so you were likely to get more chance of people not knowing each other in those such situations. Obviously, due to work pressures, people couldn't always travel from one to the next.
And then last question, it may be anything that you picked up from your observations, how to best engage the very frontline staff, so frontline nurses, and
Really tough.
it is
Really
tough.
It's very tough. I think a lot of frontline staff are engaged, but I think it's those often junior staff or those on wards who can't leave patients. It's really difficult. What the Point of Care Foundation did around that was they developed some pop-up rounds, they called them. So they took the rounds to the wards and they encouraged an add-on to a staff round or at a handover or break time. So they were short, but it was one way of trying to counter that the inability of some staff to come, which was quite striking and difficult. And so, yeah, that was one example. That's not evaluated as far as I know, but could talk to Point of Care Foundation colleagues about that.
Thank you. Yeah, that's what we also have written up as our team-based rounds, trying to take it to groups and reach folks. So thank you both so much. This has been a really great discussion. A lot of questions about resources and some of the references. So we will make sure with this recording, we post the slides, some of the articles, and then making clear on our website, we have lots of research posted about rounds. So we'll try to make that clear for folks. Thanks, Julie, for wrapping up for us.
Great. And thank you so much to our panelists and to all of you who joined us here today. We hope you enjoyed this Compassion in Action webinar, and thank you again to our sponsors. Please take a moment to fill out the very brief survey we'll be sending you after the webinar. We really appreciate your feedback on today's session. Thank you for joining us.